Today you're assigned to care for a 24-year-old patient who was recently admitted with a chest wall injury caused by a car accident.
Are you having trouble breathing, sir?
I can't breathe.
Okay. Is anything making it worse?
During your initial assessment, he reports shortness of breath and a sharp pain on the left side of his chest on inspiration. A stat chest X-ray confirms a left-sided pneumothorax. Now you must act quickly and help insert a chest tube to correct the problem and prevent further respiratory compromise.
Mr. Smith, I'm just going to give you a little bit of oxygen.
Your role in chest tube insertion and management is critical because your patient's life depends on your skills. To help you perform the role expertly, this program will show you how chest tubes work inside the body to relieve a pneumothorax or similar condition. You'll also learn how to assist with chest tube insertion and removal, set up and maintain a chest drainage system, monitor for complications, and provide other follow-up care. Chest tubes and closed chest drainage systems are ordered to remove fluid or air from the pleural and mediastinal spaces.
Right here to help you breathe a little
These
better.
devices are used to manage open or closed pneumothorax, or air in the pleural space, pleural effusion, or fluid in the pleural space, empyema, or pus in the pleural space, hemothorax, or blood and air in the pleural space, and recovery from thoracic surgery.
You're going to need to leave it on.
To understand how chest tubes and drainage systems work, consider the normal anatomy and physiology of the lungs and related thoracic structures. These elastic structures normally expand and contract to allow for respiration. During inspiration, the intercostal muscles contract to expand the chest wall, and the diaphragm contracts and moves down to create negative pressure in the lungs that allows them to fill with air. During expiration, the diaphragm and intercostal muscles relax, which allows the elastic recoil of the lungs to force air out. Two pleural membranes help make lung movement possible: the parietal pleura, which lines the thoracic cavity, and the visceral pleura, which covers the lungs. Pleural fluid lubricates the surfaces of these membranes so they can move against each other smoothly. Negative pressure in the pleural space forms a vacuum which keeps the pleural surfaces together and prevents lung collapse. However, if a pleural membrane is disrupted, the delicate balance can be disturbed. For example, if a fractured rib punctures the parietal pleura, a pneumothorax can occur. In a pneumothorax, air enters the space between the parietal and visceral pleurae, destroys the negative pressure that holds the pleurae together, and prevents normal ventilation. If air continues to enter the pleural space during inspiration and can't escape through the break in the pleura during expiration, a pneumothorax can become a tension pneumothorax. In this life-threatening emergency, pressure in the pleural space increases, further compressing the affected lung. If the pressure builds, it can compress blood vessels and shift the mediastinal contents, including the heart and bronchi. Without treatment, tension pneumothorax can lead to cardiac arrest. Chest tubes and drainage systems help relieve a pneumothorax by restoring the negative pressure in the pleural space, which allows the lung to re-expand.
So, Mr. Smith, we are going to put this chest tube in.
When your patient needs a chest tube, prepare him by explaining the procedure and providing reassurance, making sure that the physician has obtained informed consent, and administering an analgesic or a sedative as prescribed. Also, prepare the equipment, including the closed chest drainage system. To understand how this type of system works, consider its components. A disposable drainage system usually has 3 chambers, each with a different function. The drainage collection chamber collects and measures blood or other fluid that drains from the pleural or mediastinal space. It usually has at least 2 compartments to capture large amounts of drainage. The water seal chamber has a one-way valve to create negative pressure that lets air and fluid escape from the pleural space and prevents air from being pulled into the pleural space. The water level in this chamber reflects conditions in that area. For example, if pressure in the pleural space unexpectedly rises, the fluid level in the water seal chamber will fall. This chamber can also detect air leaks in the system or pleural space. In systems without a water seal chamber, an air leak monitor serves that purpose. The suction control chamber is found on systems that use wet suction. In a wet suction system, this chamber uses water to create the negative pressure needed to remove fluid or air. In contrast, a dry suction system uses a built-in device to regulate the suction amount. Generally, dry suction systems are preferred when high negative pressures are needed. Before chest tube insertion, prepare the drainage system. Fill the water seal chamber to the 2 centimeter mark. For wet suction, also fill the suction control chamber to the prescribed level, such as -20 centimeters of water. With the drainage system assembled, prepare a sterile field for chest tube insertion. For an uncomplicated pneumothorax, expect the physician to use a 14 French or smaller chest tube. To drain thick fluid or remove fluid or air rapidly, expect the physician to use a larger diameter catheter.
Okay, and lean over this table.
Help the patient into an appropriate position. If he can tolerate sitting upright, have him lean over a bedside table to accommodate a tube in the 4th or 5th intercostal space, usually lateral to the nipple line. Otherwise, help him into the lateral supine position with the affected side up. In a pneumothorax, air tends to rise high in the thoracic cavity, so the physician will direct the tube anteriorly toward the apex of the lung. In a hemothorax or empyema, gravity causes blood or other fluid to collect in lower areas, so the tube will point posteriorly and toward the base of the lungs.
Mr. Smith, let me see your ID badge.
Before the procedure begins, be sure to follow JCAHO's universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. To do this, mark the surgical site if the physician leaves the patient before starting the procedure, and call a timeout while the patient's awake in order to verify his name, identify the procedure, and confirm the surgical site. Next, assist with the procedure. Expect the physician to apply antiseptic to the insertion site. Then expect her to inject a local anesthetic, such as lidocaine, to numb the area. While the physician inserts the chest tube, reassure the patient and assess his pain level. Administer another dose of analgesic if indicated and prescribed.
Yep, there
It's
we
in,
go.
okay?
After the chest tube is in place, help the physician connect it to the drainage tube on the closed chest drainage system, keeping the connector sterile. As ordered, set up wet suction, dry suction, or gravity drainage. The type used depends on how much air must be removed and how quickly the pneumothorax must be resolved.
Try to relax and let the chest tube do its work.
If suction is ordered, attach the tubing from the suction control chamber to an external suction source, such as wall suction. For wet suction, increase the suction on the external source to produce gentle, continuous bubbling in the suction control chamber. For dry suction, set the external source to 80 millimeters of mercury, and set the suction control regulator on the chest drain to the prescribed amount. For gravity drainage, leave the suction tubing open to the room air. This lets air escape from the chest drainage system. After the physician sutures the chest tube in place, apply a dressing to the insertion site. If ordered, use petrolatum gauze to create an airtight seal around the tube. Then apply a dressing, such as fenestrated or split gauze, and 4x4 occlusive gauze. and tape the entire surface of the dressing. Secure all tube connections with tape or nylon bands to help prevent an air leak. As ordered, arrange for a chest X-ray to confirm tube placement in the patient's pleural space. After chest tube insertion, perform follow-up care. Initially, check your patient's vital signs every hour. Watch for hypotension, tachycardia, and tachypnea, which can signal a tension pneumothorax. In this complication, positive pressure in the pleural space compresses blood vessels and decreases cardiac output, the amount of blood the heart ejects in 1 minute. Low cardiac output causes hypotension. To compensate and raise the blood pressure to normal, the heart beats faster, which results in tachycardia. Also, auscultate your patient's lungs at least once every hour initially. Expect clear breath sounds to extend to the periphery of the lungs, a sign of reinflation. If the lung sounds remain diminished on the affected side, the chest tube may not be resolving the pneumothorax and may need adjustment, replacement, or increased suction.
Okay, good.
Remember to check the patient's oxygen saturation every 2 to 4 hours or as ordered. Report a level that's below 95%, a sign of hypoxemia caused by impaired ventilation. Remind the patient to cough and deep breathe at least every 2 hours. Doing so can help reinflate the lung and ease his breathing.
0 is no pain at all.
Regularly ask him about incision pain and pain with deep breathing, and administer analgesics as prescribed.
Just double check. Good.
Pain is common after chest tube insertion. That's because the procedure disrupts the parietal pleura, which contains pain receptors from the intercostal nerves. When triggered, these receptors send pain signals up the spinal cord to the brain. Check the chest tube dressings frequently to detect blood or other drainage. Change the dressings according to hospital policy. Also, palpate around the insertion site to detect subcutaneous emphysema. This complication occurs when air leaks into subcutaneous tissue and produces crepitation or a crackling sound on palpation.
How are things going here?
Well, actually, doctor, I think there's a little crepitus
If
here.
you detect subcutaneous emphysema, immediately notify the physician, who may reposition the chest tube. To facilitate chest drainage, reposition your patient at least every 2 hours and maintain a high Fowler's or semi-Fowler's position if tolerated. Check the character and volume of the chest drainage once every hour or more often. Near the drainage chamber, mark the date, time, and fluid level according to hospital policy. Notify the physician if chest drainage exceeds 100 milliliters per hour. Excessive drainage can signal hemorrhage, which may require surgery. When the drainage collection chambers are nearly full, replace the system. To do this, prepare the new system and clamp the chest tube. Then quickly disconnect the old system and reconnect the new one. After unclamping the chest tube, make sure the drainage system is working properly. Regularly check the water seal chamber for tidling. The water levels normal rise and fall with respiration. During inhalation, the pressure in the pleural space becomes more negative, raising the water level in the chamber. During exhalation, the pressure level returns to baseline, and so does the water level in the chamber. The absence of tidling commonly indicates an obstruction, which can occur when the tubing is kinked, compressed, or clogged, or has a dependent loop. Absence of tidling can also occur when the lung is reinflated because the negative pressure in the pleural space is restored. Also look for bubbling in the water seal chamber. Normally, you should expect bubbling immediately after the drainage system is attached to suction, when a small leak occurs in the pleural space, and when the patient coughs or exhales. If you spot unexpected bubbling in the water seal chamber, notify the physician and assess the patient for signs of respiratory distress.
That's great.
Suspect a new air leak, which can occur when air enters the drainage system or the pleural space. To locate an air leak, place a padded clamp on the tubing closest to the insertion site. To avoid raising the pressure in the pleural space, don't clamp the tubing for more than 10 seconds at a time. With the clamp in place, check the water seal chamber for continued bubbling. If the bubbling stops when the clamp is placed near the chest wall, suspect an air leak in the pleural space or the lung. If the bubbling persists, apply the clamp at close intervals, moving along the tubing toward the drainage system. When the bubbling stops, suspect an air leak proximal to the clamp. That's because placing a clamp between the water seal chamber and the air leak blocks the air that causes the bubbling. Depending on the air leak's location and cause, remedy the problem by tightening loose connections or replacing the drainage system. Next, check the suction control chamber. For a patient receiving wet suction, assess the chamber's water level by briefly stopping the suction to halt the bubbling. Then inspect the water level, which should be at the prescribed amount, such as -20 centimeters. If the water has evaporated and its level is low, add enough water to reach the amount ordered. For a patient receiving dry suction, make sure the suction control regulator is set at the prescribed amount. To help determine the effectiveness of the chest tube and drainage system, thoroughly document your assessment findings. For a patient whose pneumothorax is resolving, expect to record normal, easy respirations without dyspnea, symmetrical breath sounds that reach the periphery of the lungs, including both apices and bases, reduced drainage in the collection chamber, little or no titling in the water seal chamber as a sign of lung reinflation, and a chest X-ray that shows resolution of the pneumothorax.
Excuse me, doctor. Mr. Smith is doing pretty well. His respirations have been good. His oxygen saturation has been greater than 95%. Also, he's had no shortness of breath.
When the pneumothorax has resolved, prepare to help the physician remove the chest tube and discontinue the drainage system. To confirm that the patient's ready for chest tube removal, assess for symptoms such as dyspnea and chest pain after the tube has been clamped. Within 2 hours, send the patient for a chest X-ray to verify continued lung reinflation. Then prepare the equipment for chest tube removal. Be sure to include a suture removal kit, 4x4 gauze pads, sterile gloves, petrolatum gauze, surgical tape, and clamps. After providing analgesia or sedation, begin the procedure by clamping the chest tube if this wasn't done earlier. Then remove the dressings from the chest tube insertion site. When the physician is ready to remove the tube, expect her to have the patient perform the Valsalva maneuver and bear down.
1, 2, 3.
This maneuver helps prevent air from rushing into the pleural space when the chest tube is removed. As soon as the physician withdraws the chest tube, cover the insertion site with petrolatum gauze and 4x4 gauze dressings. Secure the dressings with surgical tape and provide other follow-up care. For example, send the patient for a chest X-ray to confirm that the pneumothorax hasn't recurred. Continue to monitor the patient for signs of recurrence of the pneumothorax and evaluate and document his condition. Be sure to ask about chest pain and shortness of breath. Auscultate his breath sounds at least every 4 hours to check for diminished sounds. Monitor his oxygen saturation level to detect hypoxemia. Assess the chest tube site for signs of infection. And monitor chest X-rays for recurrent pneumothorax.
Mr. Smith.
As you've just seen, your role in caring for patients with chest tubes is a challenging one that requires expert clinical skills. But you can rise to that challenge every time when you know what to do before, during, and after chest tube insertion.